Thank you very much, Kachan. I'm delighted to be able to address this important topic, but my goal for you is to impart the background necessary to serve as an astute consultant for the patients being treated with immune checkpoint inhibitors or ICIs and their oncologists. And the goal, as I will elaborate, is to not overtreat and overdiagnose this condition because it leads to the abandonment of the ICIs, which are imperative for the patient's survival. These are my disclosures. Now, for us to understand ICIs, we first must understand that negative co-stimulation is key for immunoregulatory control of activated T cells. If we didn't have that, we'd be one big lymph node for all the activation that we have through our life. You have to activate and then you have to terminate. And that's done with activated T cells expressing CTLA-4 that binds 20-fold higher affinity to the co-stimulatory molecules B7, 1, and 2. And simultaneously, that activated T cell expresses programmed death receptor PD-1, which can then be activated by PD ligands 1 and 2. Now, that's shown here for an antigen-presenting cell. That's the normal physiology. But those ligands are also present on tumor cells, and it's one of the ways that tumors create an environment where the immune system cannot overcome them. So that is the background, and when we look here, we know that in 2018, James Allison and Tasuku Honjo received the Nobel Prize in Medicine and Physiology for the introduction of 3 ICIs classed as a CTLA-4, the PD-1, and the PD ligand 1 antagonists. And you all know that that has revolutionized cancer chemotherapy. Now you see at the bottom left that normally the tumor cell would engage with the CTLA-4 and it would inhibit that T cell and send it into its demise. But when you block it, that T cell remains cytotoxically active and can now kill that tumor cell. To the right, you see the PD-1 and PD-L1 interactions, and the same thing applies. On the left panel, to the right side, you see that if the PD-1 engages with PD-L1, it's going to send an apoptotic signal to the T cell. And so it's going to enhance its demise. But on the right, you see when these blocked, then that T cell can remain cytotoxically active. Now I'm showing you tumor cells. But if you're thinking about this, you would realize immediately that the ICIs will promote the function, survival, and action of all activated T cells, not just those that might attack the tumor. And that means that you are ending up with a systemically activated immune system against all antigens, including those that might cross-react with self-antigens, leading to off-target issues. Now let's turn to the 3 major categories for our discussion and to become the astute consultants we want to be. First, we introduce immune-mediated liver injury caused by immune checkpoint inhibitors, or ILICI. This is the new term for checkpoint inhibitor toxicities. Now, it is a specific type of hepatic immune-related adverse event, or IRAEs, and it is preceded and or accompanied by other IRAEs, as you see in the left panels. The incidence is 10 to 15%, and that is sort of lowest for single ICI use and higher for combination use, and often higher still for patients with chronic liver disease, which of course in our field are the cirrhotic patients being treated for hepatocellular carcinoma, not resectable or not amenable to transplantation. The clinical features are a latency of about 6 to 14 weeks after the ICI is used. The most predominant presentation is asymptomatic acute elevations of the aminotransferases, which if you're patient enough, you will start to see resolve spontaneously without holding the ICI. It's severe in only 2 to 3%, and that's really one of the take-home messages. Of 100 patients you might consult on, only 2 to 3% may need an intervention by you. And it's especially enhanced in those that having underlying chronic liver diseases or the cirrhotics with HCC. Now, imaging is pretty nonspecific and not terribly helpful. We're going to review the histology in more detail as we further in the talk. But I want to emphasize that there is always a differential diagnosis, and we'll talk more about the detail of that. And that's really where the consultant hepatologist and gastroenterologist can make the difference. Now, the next entity in this sort of continuum is drug-induced autoimmune-like hepatitis, which is the new terminology for a drug-induced clinical pathological phenotype among many phenotypes of hepatic DILI, which you can see categorized on the right. It has clinical, biochemical, serological, and histologic features that are similar to those of classic autoimmune hepatitis, or AIH. Now, it's often indistinguishable from AIH prior to a period of observation of the response to discontinuation of the drug and or the addition of immunosuppression, usually corticosteroid alone, and the absence of a relapse when you withdraw the corticosteroid immunosuppression. We're plagued by the fact that we have no biomarker, and we desperately need one. Now, finally, you have classic autoimmune hepatitis, and you all know that that is a syndrome, and that syndrome is of a progressive hepatitis resulting from loss of tolerance to hepatic autoantigens that is characterized by increase of aminotransferases due to the hepatocellular necroinflammation, autoantibodies, increase in IgG, and or hypergammaglobulinemia, and non-pathognomonic histopathology, which involves interface hepatitis principally and central perivenulitis. It is obviously responsive to immunosuppression as part of its sort of diagnostic criteria. And again, we have an absence of a diagnostic biomarker. Now, you're well aware that this can present as acute liver failure and acute hepatitis, or as chronic hepatitis, or even present as established cirrhosis. And most importantly, in the illicit field, you don't get acute liver failure, but you do get acute hepatitis, and that's where the differential is going to lie between acute onset AIH and illicit as a hepatitis. Now, illicit's immunopathogenesis is incompletely understood. It's a work in progress. And in fact, there's a poster on that in animal models from Lily Dara's group at USC that you might find interesting out in the lobby. At the top, you see that the ICIs, as I've shared with you, promote survival and functions of cytotoxic T cells, and they're key to killing the malignant cells. That's where the money is for the patient being treated. However, it did create, as I told you, a pan-T cell response and survival of function, leading to systemic inflammatory responses, off-target cytokine and chemokine effects. And in chronic liver diseases, or those that suffer from DILI due to other drugs or herbal or dietary supplements, it can be intensified. And the sum total of that leads to hepatic immunological responses, homing of cytotoxic T cells to the liver, activation of inflammasomes, the activation of recruitment of NK, NKT, and macrophages in response to the injured hepatocytes, and the potential release of neoantigens, some of which could be cross-reactive with self-antigens. And that then leads to hepatic necroinflammation with very little fibrosis. A very key finding, very little fibrosis is anticipated if you biopsy these patients. And as you see in the cartoon, it is a process of apoptosis associated with CD4 and CD8 T cells and innate cells. The most easily recognizable in light microscopy are going to be the macrophage content of the portal and the lobular inflammatory infiltrates, which is right different than what one sees in autoimmune hepatitis or the DIL-H autoimmune-like hepatitis due to drug. Now, when you have such an injury going on in the liver, it is always possible, but this is only theoretical, that it will act as a trigger for AIH in patients who have immunogenetic susceptibility. Now, this slide compares the immunopathogenesis of DIL-H and classic AIH and notes the key differences in immunopathogenesis. First, to the left, vertically, we have DIL-H, Drug metabolites bind to proteins inside hepatocytes, and these induce changes in the cells that cause immunologic responses, activation of hepatocyte inflammasomes, injured and dying hepatocytes, and possibly neoantigen release for processing and presentation to the adaptive immune system. And it culminates in hepatic necroinflammation, again with scant fibrosis, because it's a fairly acute event that you're called on to assess. Now, to the right, we see that in contrast, AIH requires a genetic predisposition and environmental triggers that lead to the key loss of self-tolerance to hepatocyte autoantigens, plus a failure of immunoregulatory cell function that would normally regulate that. And because you have this dysregulated autoantigen-specific process, you end up with hepatic necroinflammation, which is quite fibrogenic. And even in acute hepatitis, you can, due to AIH, you can see more evidence of fibrosis than in any of the other forms. So we then, well, I'm sorry, let me go back. That was an ad. I wanted to call attention to the fact that when you have destroyed hepatocytes, in this case due to DILI, that we believe that DILI, either DIL-H or just DILI alone injuring hepatocytes, may be the culprit that acts as an environmental trigger in up to 9 to 12% of AIH patients. But that is a speculation. So how do we summarize? We know that the liver on the left is an immune homeostatic organ of tolerance. If we didn't have tolerance in the liver, we would just be replete with food, allergens, and reactions. We wouldn't be able to regulate virtually anything in our immune response. So we have an immunotolerogenic liver. But what we've done with the checkpoint inhibitors is we've allowed the cells that are fully activated to keep flooding into the liver. And what's not on this slide, but is an important concept, is that the liver is the elephant graveyard for all T cell demise. That's where every activated T cell dies. It dies in your liver because normally the PDL ligands are expressed on liver sinusoidal endothelial cells and Kupffer cells, and they deliver the death signal to these now exhausted and senescent T cells. So it's not surprising that you're going to congregate a lot of T cells there. And when they're fully active in cytokines and they've got their granzymes, they've got other receptors that will induce cytotoxicity, you can see easily that you can get apoptosis of the hepatocytes and recruit a lot of macrophages and perpetuate that injury. Now, for the money slide, where I'm asked to compare Illicity and classic AIH, you will note in this comparative slide that there are substantial clinical pathological differences between the two. Just let your eye go to the center here and note that with AIH, you have a female predisposition, which you do not have with Illicity. You've got anti-nuclear antibodies and anti-smooth muscle antibodies, often in high titer, as opposed to low titer or absent autoantibodies in Illicity. You have lobular inflammation, you have plasmacytosis, you have increased CD20 B cells in the infiltrates within the liver, as well as CD4, T helper 1, and T helper 17 predominant cells, both absent in the typical Illicity. And then you have the recurrence after checkpoint inhibitor withdrawal, because you're dealing with AIH. So you take away the checkpoint inhibitor, it doesn't do really anything. The disease stays bad unless you immunosuppress. So it is not the same disease. And if there's any message I leave with you, it's that when you find your patient you're consulting with Illicity, this is probably the rarest possibility that they actually have AIH. Now, this gets to the utility of liver biopsies that I'm going to show you in some diagnostic algorithms yet to come. And that on the left shows the published experience of the major features of Illicity. And you can sort of see that there are multiple ones. And to the middle, you see the three classic features that characterize AIH. They are different. So you might say, well, a biopsy is going to tell us all that we need to know. But the purpose of this slide is to look on the right, which shows as a heat map the intensity of individual biopsy findings, which are sort of angled at the bottom of the slide. So let me call attention to the fact that when you look at portal infiltrates in interface hepatitis, the most intense being in the yellow, you see that both autoimmune hepatitis, the bottom patients, and to the top, the illicit patients, they both have this. When you look at lobular inflammation and lobular necrosis, you again see an array seen in both patient groups' biopsy. When you look at granulomas, you find it exclusively in the illicit group. And when you look at plasma cell infiltrates, you see much more, but not exclusive evidence within the AIH group. So the message here is that when your pathologist doing the due diligence of reading a biopsy you get starts to comment on these features, it's our role as hepatologists and consulting gastroenterologists to say, wait a minute, we know that these features can be nonspecific because they're not pathognomonic. That's the key. So don't let a pathologist say this is autoimmune. It doesn't mean that. You have to be much more astute because you have to put autoimmunity into the syndrome, only part of which is histology. Now, managing toxicities of ICIs is requiring all of us to keep our focus on cancer-free survival. That's what the patient wants, that's what the oncologist wants, that's what we should be doing as consultants. So we want to promote that the cytotoxicity of malignant cells. And if we recommend withdrawal of the ICI or immunosuppression, we are going to put that at risk. And if we actually then go further and DC the ICI and give intense immunosuppression, we're going to have an ICI non-responder. So if we choose to do that because of the clinical need of the patient, we hope that we can be temporizing that we can withdraw immunosuppression quickly and that we can consider reintroduction of the ICI. Obviously, they still have malignant disease. And this looks now at the value and importance of early consultation with a hepatologist. And the hepatologist figures are in the red. And you can see that early consultation here for 117 consecutive so-called illicit or at-risk illicit patients significantly hastened the normalization of ALT because of the input of the hepatologist, the reduction of ALT to less than 100, and the use, when necessary, of additional immunosuppression, which is not going to be needed for any more than that 2 to 3% of the patients we're going to be called on to consult with. Now, this is another money slide. This is where our training comes to bear, and it's not the purview of the oncologist, and that is, first, be sure it's illicit. There's a differential diagnosis to be had in all patients. We're well aware of reactivation and potential of hepatitis B, the under-testing to know that these patients should be prophylaxed to prevent that. And there's a variety of issues here that every one of them deserves to be scrutinized, just like a pilot's checklist. Is there any potential possibility your patient has one of these? Because if they do, it is likely the cause of the aminotransferase elevation rather than illicit. So once you have done that, then experts in the field, and this is from Bob Fontana, in representing the Drug-Induced Liver Injury Network of NIDDK, you come to algorithms of how you might respond. Now, across the top in green, we see grades based on the common terminology criteria of adverse events, which are used throughout our field as well as FDA, as well as oncology. And you see the different grades. Going vertically, you see the time course of the drug-induced liver injury, the abnormal liver tests. And to the far left, you see that if you have grade 1, you don't have to withdraw the ICI, you just need to monitor because I told you that it's most likely going to resolve. And you can take it on down to a longer-term observation. If it doesn't resolve and gets worse and it moves over to grade 2 or 3, this algorithm recommends that you hold the ICI and that you consider the addition of oral corticosteroid, prednisone. Now, if that works, you can see the pathway going on down to the left. If it doesn't work, then the question is, are you missing something and should you do a liver biopsy? But I hope I've already shared with you that the liver biopsy is going to be helpful, but it is not in itself going to be large diagnostic. Now, in contrast, if you have grade 3 that advances over to 4, or you start with grade 4, then they want to stop the ICI, and they recommend the use of intravenous methylprednisolone. But I want you to be very, very careful about that, because most people are not fully aware that intravenous methylprednisolone, particularly in oncology settings, can itself be hepatotoxic. So if you give that with the anticipation it's going to help and the patient doesn't get better or gets worse, you may have actually given an hepatotoxic agent. And that's not well recognized, so I hope you'll take that message away. There's excellent literature on that, and all the makers of checkpoint inhibitors have that buried in the information that they try to provide practitioners. Again, you see a role for liver biopsy and the possibility of using, in this case, an anti-proliferative, mycophenolate mofetil, abbreviated MMF, and then if all else is failing, then you might be making a recommendation for advanced immunosuppression with calcineurin inhibitors or other agents. That ought to be recommended by you, not by the oncologist. That's sort of, and if you're uncomfortable with that, you've got a lot of transplant hepatologists, a lot of IBD-ologists as colleagues, get their input. So that's one way of looking at it. Now, this is a newer way of looking at it, which I think has a lot of merit, because remember, the goal is to keep them on the ICI if at all possible. This looks at management algorithm based on grades and tries to maximize ICI efficacy and minimize the use of immunosuppression. So what they did here is that they're holding the ICI and they're categorizing the patient. And the most important aspect is in the middle of the slide. When you have higher grades, is whether they do a liver biopsy and then they decide about corticosteroid use based on the intensity of inflammation in the biopsy. And you can see that 2 of the 3 categories get no corticosteroid. And that is kind of a new wrinkle here, a way of avoiding, and this has been validated, and the publication reference there is quite new and is well worth knowing about. Now, let's look at illicit incidence, risk factors, and severity. In this case, a 10-year real-world retrospective cohort study. You see this is 432 patients. You can see in the middle that they had an 8.8% total incident, cumulative incident of abnormal liver tests. The risk factors included the combination of ICIs, which is known. In this case, female sex was quite prominent as a risk factor, low baseline alkaline phosphatase and high baseline ALT on multivariate analyses. You can see the latency and the 1-year probabilities were highest for the combination therapy at 32%, and then they were less than 3% each for the CTLA-4 and the PD-1. Importantly, in the bottom right, you see that when you look at DILI criteria, these patients had mild to moderate histopathology. Remember the slide before, you might not need to treat with corticosteroids, but it dissociates from the CTCAE grades, which were severe and considered even in the life-threatening range in 20%. So what you have here is that the risk may be greater in this study than previously thought. Women were more prone in this study, but most importantly, that the grades on the CTCAE overestimated the necroinflammation and might prompt you unnecessarily to treat a patient. This looks at 117 patients retrospectively, and I want to concentrate on the middle panel, which divides the patients into those who had cholestatic injury by their biochemical profile, hepatocellular or mixed. To the top right, you see the variety of treatments, including no treatment and including combination therapies. And to the bottom, you see that 12 out of 51 patients that had resolved were reintroduced with the ICI. And they had about a quarter of them, 1 out of 4, that went back to a toxicity. But Said the other way, 75% didn't and were allowed to proceed with life-saving therapy. Now, the burden of grade 3 or 4 liver injury in multi-center cohort here of 952 patients, I chose this specific study because of its size. You've got 100 boxes of patients. Only 9 of them are colored. If you look at the 4 in deep purple, those are non-Illicet abnormalities of the liver. If you look at the light purple, they're also not Illicet cases. The 2 in green, the 2%, were in green. If you look, there was no ALF. Risk factors were the combinations. In this case, chronic hepatitis B, which was subject to reactivation. Withdrawal of ICI led to cancer progression. That's what we want to prevent happening. And restarting the ICIs was not associated with recurrent grade 3 or 4 injury. To the right, you see at the top that CTLA-4 had a higher rate of grade 3 or 4 injury in those that didn't receive it. You say, well, that fits, but look at the bottom. The highest rate of injury was in those that did not receive PD-1 or PD-L1 inhibition. And this gets to a part that I can't discuss because of time, and that is there's a high variability in the grades and the type of cancer and the type of immunotherapy that is used for different types of cancer. And this is becoming more complex, but it's ultimately going to be, with the aiding of AI, I think, reduced to some algorithms to help patients and clinicians. So my take-home points are the following. ICIs have revolutionized treatment of solid organ cancers, including, for our patient population, cirrhotics with HCC. Illicet is one of several immune-related AEs of immune complex inhibitors. ICIs induce liver-related AEs in about 10%, but only 2 to 3% are actually due to what we believe is definitionally illicit. They are due to other DILI, they're due to underlying changes of the liver, they're due to chronic drugs, et cetera. The diagnosis of illicit is based on the clinical context and exclusion of alternative comorbid causes of liver injury to prevent the unnecessary interruption of ICI therapy. Treatment includes holding the ICI, use of corticosteroids, and subsequent use of additional immunosuppressants for those that are truly steroid refractory patients. ICIs can be reintroduced after resolution of illicit, which is good news for all of our patients. And so I thank you with one of my photographs of a Catalina sunset.